All right, so we're going to continue with part 2 of immunity function disorders. And in this particular PowerPoint, we'll talk about some allergic reactions, hypersensitivity reactions, not so much on the autoimmune disorders because we've talked about those already, but we may mention them in relation to hypersensitivity and just some of the things that can affect your immune system functioning. There are several things that can affect your immune system. Some of them are considered to be genetic, and you already know by that name that genetic means that basically they're innate, you're born with them. So there's primarily not much you can do with that. So different things that can affect your immune system, some of them are considered genetic, you're born with that. Some other things that can affect your immune system are considered secondary immunodeficiencies. So this is maybe how you are relating in the world, how you're eating, how much stress you have, what types of injuries have happened to you. All of those things can affect your immune system. So this includes things like your diet, malnutrition, chronic stress, burns, having things like uremia. Maybe we've seen this in kidney failure, for instance, having conditions like diabetes mellitus, having some type of autoimmune disorders, being on some types of medications, in particular steroids come to mind. They can definitely affect your immune system, being exposed to chemicals, doing recreational drugs, and for sure, drinking. And we know that this is something we have to be concerned about when it comes to alcohol, because now we know that with COVID-19, if people are drinking a lot, if people are stressed, as is being reported, that if you do end up contracting the virus, that if you are doing those things, then you have a higher chance of actually becoming really, really sick and dying from COVID-19. So these are actually realistic things that somebody can have happening to them. Recreational drugs include things like cocaine, maybe opioid abuse, etc. Your autoimmune disorders, that could be just a defect in your immune system that's going on. All right, so several different things can affect your immune system. Some of them are considered genetic and some of them are considered secondary. So with the immune system dysfunction, we have what is known as an allergic reaction. So by definition, an allergic reaction occurs when the immune system recognizes a foreign substance the body would normally ignore. So it recognizes a foreign substance the body would normally ignore. So normally, maybe there is dog hair around or there's cat hair around. Normally, yeah, you just ignore it. Your body sees it. It's not the end of the world, right? But in some cases, though, you get what is known as an inflammatory response is initiated, and then this can include hypersensitivity to a substance that ends up happening, right? So the interesting thing about hypersensitivity reactions or allergic reactions, the theory is that you don't become allergic to something the first time you come in contact with it. Supposedly, it takes time. Like you have to come into contact with something several times, and then later on, you actually may end up having an inflammatory response, and then you have this really weird hypersensitivity reaction. So your body takes time to build up antibodies, and then the next time it sees it, it just reacts in this really aggressive way. So that is one of the theories. Although sometimes it feels like you come in contact with cat hair and you go crazy, you get swollen, and everything goes nuts for you. But apparently, the theory is you don't really react the first time you've met something. And this might be true because even like I never used to have allergies, but now all of a sudden I'm sneezing, I'm going crazy, and then like pollen counts never used to affect me at all. So there is some truth to that particular statement. All right. Then we have what are considered autoimmune disorders, and in this particular case, the immune system mistakenly sees the body's own tissue as an antigen or a foreign body and attacks it. So we've already talked about the fact that autoimmune disorders are more common in women, and we're thinking that estrogen is thought to play a role because it modulates activity of the T lymphocytes in particular. So immune system dysfunctions can happen primarily because of allergic reactions going on or autoimmune disorders being issues as well. All right, with the allergic reaction, So an allergic reaction is an inappropriate and sometimes dangerous response by the immune system to a normally harmless substance. So we've mentioned things like dog hair, cat hair, or even pollen, right? Chemical mediators initiate a response to produce antibodies against normally innocuous substances. And allergic responses can range from mild to severe to life-threatening. So all of that is possible. Here we have a picture of allergic reactions and how they could happen. So you've been given different types of examples. So it could be skin contact, poison plants, animal scratches, pollen or latex, by injection, by via bee stings, by ingestion, maybe it's medications, nuts and shellfish, or by inhalation, maybe it's by pollen, dust, mold and mildew, and animal dander. So all of these are things that can potentially cause an allergic reaction. So it's happening for many different types of things. So the particular cells that are involved in the allergic reactions, so they include the B cells, they include the T cells, and also your mast cells. So the other ones, remember, that are responsible for the chemical mediators. In particular, we talked about histamine. Right? So histamine is a chemical that's released from the mast cells, and with that, what are you going to be getting? You're going to be getting things like erythema, localized edema, wheals and hives, pruritus, and contraction of the bronchial smooth muscles, right? So all of these different things can be happening. This is just a picture of a sequence of when an allergic reaction occurs. And this is the statement that I made to you earlier, that an allergic reaction does not occur the first exposure to the allergen, right? It apparently takes time for it to basically build up. So a person is exposed to ragweed, for instance. That's an allergen, right? So they've come across ragweed. Then they make large amounts of ragweed IgE antibodies. Your body basically creates this IgE antibody to ragweed, and that's what they'll be looking for later on to see whether or not you're allergic to ragweed if they were ever to do any type of blood work on you. So they're attaching themselves to mast cells. And remember what mast cells would do. They're the ones that are doing things like histamine, and then they create this whole crazy reaction that happens. Then the second time you meet that ragweed, now your IgE basically has become primed, and they're going to release those powerful chemicals. So you're going to get things like wheezing and sneezing, runny nose, watery eyes are the symptoms that are going on. If you have to diagnose the allergic reactions, there are different ways that they can do this. So they can do a CBC with WBC differential. The WBC differential means that they're looking at some of the mast cells, and they're looking for very specific white blood cells. So are they looking for leukocytes? Are they looking for neutrophils, lymphocytes, etc.? Right? They're looking to see whether it's a bacterial component or is it a viral component that's going on. So they're just really differentiating the WBCs and seeing what is proliferating, so they can have an idea of what's happening in your patient. So once again, not overthinking, just knowing that this is a capacity that we're able to do. They can do what is known as a RAST. So in here, they're specifically looking for the IgE antibodies for these specific allergens. So this is a blood test that they're doing, and they're looking to see whether or not you are allergic to particular things. They can do skin tests. So they're identifying specific allergens that can cause allergic symptoms in the patient. So they could do this with patch testing on the skin, and then they're seeing whether or not you are reacting to whatever they're putting on your skin based on a particular time frame and based on how much of a wheal or like of much of a swelling that you get after they've applied whatever agent to your skin. So now we're going to talk specifically about the altered immune system, and we're specifically going to talk about hypersensitivity reactions that can happen. All right, so with the altered immune system, what do we have to do? So we're going to be doing an aggressive health history. We have some information that autoimmune disorders are more prevalent in women than in men. So family history is important, and we're also going to be assessing the genetic component for that. So the physical assessment is the same like anything else. It's inspection, it's palpation, looking at the general appearance, inspecting mucous membranes, the nose and the mouth, inspecting and palpating the joints, assessing the skin color, temperature, and moisture. So it's a very focused assessment that you're doing on your patient. So hypersensitivity, by definition, is an altered immune response to an antigen that results in harm to the patient. So it's an altered immune response to an antigen that results in harm to the patient. So just focus on the word altered immune response. So it can lead to inflammation and destruction of the healthy tissue. And when the antigen itself that is causing this altered immune response is environmental, they may call that an allergy. All right. So keyword still is that hypersensitivity is an altered immune response to an antigen that results in harm to the patient. And when the antigen is environmental, they may call that an allergy. So the tissue response to a hypersensitivity reaction may lead to runny nose, itchy eyes to life-threatening, blood cell hemolysis, or laryngospasm. So all of this can happen. So hypersensitivity reactions are classified as immediate or delayed. They can lead to inflammation and destruction of healthy tissue. Anaphylaxis and transfusion reactions can be considered immediate hypersensitivity reactions. Things like contact dermatitis can be considered a delayed response. And most allergic reactions are either type 1 or type 4 hypersensitivity reactions. So most allergic reactions are either type 1, meaning that they're very explosive, they happen right away. So maybe you got bit, I don't know, by a bee or something. That reaction is going to be very explosive right away. Or it could be type 4, meaning maybe you put on like a pair of gloves, let's say, and maybe for you, the pair of gloves doesn't really react. It takes a while for that, whatever that powder is inside the glove to build up. So it may happen maybe 72 hours later, let's say. So that might be one example. And then, so later on, we're going to have some examples of what that may look like. I'm encouraging you to look at page 1060, figure 37-2, because you have to be able to look at hypersensitivity reactions between type 1 through type 4. You have to know what the different types are. These slides have some examples, but you need to be able to know the other ones that are in your chart as well. All right, so for type 1, it's an immediate reaction beginning within minutes of exposure to an antigen, and it can literally affect your skin, your lungs, your GI tract. And with type 1, it's important to know that it can include both local and systemic anaphylaxis types of reactions. So something, an allergen, will interact with the IgE-bound mast cells, right? So you know you're going to get those primary chemical mediators, you're going to get the histamine release, all of that is going to happen. And the clinical symptoms are going to be determined by the amount of mediators released, sensitivity of the target organ, and the route of the allergen entry. So maybe on the skin versus you inhaling it, right? Maybe the inhalation allergen is going to create a lot more trouble for the patient than, let's say, if you just came in contact with it on the skin. But key thing about type 1 is that immediate reaction beginning within minutes of exposure, and the fact that the most severe hypersensitivity reaction is anaphylaxis. The onset tends to be explosive, and you can end up with local and systemic anaphylaxis from this. Our examples of type 1 hypersensitivity, once again, you're looking at the chart in your book as well, are things like allergic asthma, and in particular, we're talking about extrinsic asthma. So this is stuff from the outside. So this could be stuff that normally wouldn't be an issue, things like pollen or dust even. In some patients, this can make the patient have an acute asthmatic attack. Things like allergic rhinitis, hay fever, allergic conjunctivitis, the fact that the patient is having hives or urticaria, and anaphylactic shock. So these are some of the components that you may be seeing in a patient that has a type 1 hypersensitivity. So they may have had something to eat even, and next thing you know, they have all these hives and urticaria. So these would be considered the manifestations from the fact that they ate something and now they're getting all these hives. And it's pretty sudden, it's pretty quick. You can take a bite of something and then right away you're going to see the hypersensitivity, the altered immune response that's happening right away. So what you're getting is a rapid release of IgE mediated chemicals, and they can literally induce a severe life-threatening allergic reaction. All right. With the cytotoxic hypersensitivity, these are classified as being type 2. So here we want to focus on the word mistaken identity, basically. So the system mistakenly identifies a normal constituent of the body as foreign. So you're getting a cross-reacting antibody, cell, and tissue damage that's going on. So here the examples given are things like myasthenia gravis. The body mistakenly generates antibodies against the nerve endings. The other one is a Goodpasture syndrome. Antibodies against the lung and renal tissue, and then you're ending up with lung damage and kidney injury. So you may end up also here with red blood cell destruction, which may be associated also with hemolytic anemia. All right. And some blood transfusion can actually be classified also as cytotoxic. Just because of the fact that of the red blood cell destruction that happens. So the blood transfusion reactions actually are pretty complex in some cases. So some of them can come under the category of cytotoxic here. All right. So once again, look at your chart just to see the other things that can fall under this category. Immune complex type 3 hypersensitivity. So this, we're specifically talking about the fact that they're immune complexes and they've formed antigens that are binding with antibodies. And then these antigens, antibody complexes are basically traveling within your tissue that go to your joints and your kidneys. So in particular, these conditions that come to mind are systemic lupus erythematosus as well as rheumatoid arthritis. Those are our bigger examples here. Your type 4 hypersensitivity is considered a delayed hypersensitivity, so it occurs 24 to 72 hours after exposure to an allergen. Contact dermatitis is an example that comes here, resulting in exposure to allergens. So maybe you put on cosmetics and you put on some makeup in the morning, and then I don't know, the end of the day, you have these hives that have shown up, right? Or adhesive tape, topical agents like povidone iodine, so they're not going to necessarily be a problem until 24 to 72 hours later. So you're going to get things like itching, erythema, and raised lesions. So there are several skin tests for allergies that they can do, and they're trying to figure out specific allergens to which a person may be sensitive. So they can do prick testing. So they do just a little, they stick you with a little bit of a needle with the allergen on it, and it's just a little bit onto a tiny area on your skin, and they don't want to use a big patch of your skin right away because they don't want you to have a systemic reaction and go into shock, right? So a drop of diluted allergenic extract is placed on the skin, and the skin is then pricked. A positive test says that they have localized pruritic wheal and erythema occurs. So with a positive test, you have a localized pruritic wheal and erythema has occurred, and the response for this test can be anywhere from 15 to 20 minutes. So that's what the rest of that slide is saying. The response can be anywhere from 15 to 20 minutes. All right. Another one that they can do is patch testing. So then maybe here they can do 1-inch patch of your skin, and they've impregnated that with the allergen. So it could be perfume, cosmetics, or detergents. They apply it to skin for 48 hours. If it's negative, that means there's no response whatsoever. If it's positive response, then you're going to see things like erythema, or in some cases you're going to see severe erythema with papules and vesicle formation. So they are graded from mild to severe, and they'll look to see how much of a wheal you form. So just know that this is out there, and they can do this as well. They've got other diagnostic studies that they can do to identify possible allergens or hypersensitivity reactions. So they can look at your WBC count for the specific differentiation that's going on. They can do the RAST, which is a blood test that measures the amount of IgE that's being directed towards specific allergens. They can do a blood type and cross match, especially when they're looking to give you a blood transfusion, which absolutely makes sense. All right, now we're just talking about different types of hypersensitivity reactions. So allergic rhinitis was considered a type 1 hypersensitivity reaction. So this one is considered a seasonal allergy, right? It's a common form of respiratory allergy. It's induced by airborne pollens or molds, and it usually happens at the same time of the year, right? So it's weather related, same time of the year. So you're looking at it needs warm, damp weather. It's usually in the early spring, and then it tapers off at some point. So you just want to know that this is something that's seasonal. So in terms of when you're doing your teaching, you're making sure that the patient knows that. So they become sensitive by ingestion or inhalation of the antigen, and then histamine is the main thing that's happening with these particular patients. Okay. You're going to be seeing sneezing, nasal congestion, clear watery nasal drainage, and nasal itching with allergic rhinitis. Headache, pain over paranasal sinuses, and epistaxis may also be seen. So you're going to do all the different types of testing that we talked about already. So history and physical, nasal smears, patch intradermal testing, and RAST, which is a blood test as well. Nasal smears, you're just looking for funky stuff in the mucus. All right, so this is an example of what allergic rhinitis may look like. So look at the red, itchy, watery eyes, sneezing, congestion, runny nose, itchy or sore throat, post-nasal drip, and coughing. Your medical management is to provide relief from the symptoms. So there are different ways you can do this. So avoidance therapy, and that essentially means just stay away from whatever is causing you to get this allergic rhinitis. So if it's flowers, stay away from flowers. If it's dogs, stay away from dogs, whatever it is. If it's seasonal, and damp weather, mold, whatever, you're staying away from that. So avoidance therapy literally means just stay away from whatever it is that's causing this allergic rhinitis to be happening in you. Pharmacologic therapy, that may be antihistamines that are being given for you. And another thing they can do is immunotherapy. So we'll talk about this a little bit later. And it's something that they do in some patients where sometimes they give you a lot of the allergen itself to boost up your immune system. And apparently this works in some patients. So obviously they're not going to be doing this for everybody, because you don't want to give somebody the allergen and then they end up being worse, right? So this is something that we'll table for right now, but we'll talk about it later on. All right, so avoidance therapy, stay away from whatever is precipitating it. So if it's air conditioners, stay away from those. Sleeping with the windows closed, removal of pets from the home, the bedroom, humidifiers, making sure you're using them, removal of dust, catching furnishings, all of that, right? For the pharmacologic therapy, you're trying to suppress the effects of histamine on the body. So primarily they're using antihistamines to manage mild allergic reactions, and they are primarily protecting the surrounding tissue from the effects of the histamine release. So it can be oral, it can be things like Benadryl, right? Side effects include things like drowsiness and a dry mouth. Other medications are loratadine, Zyrtec. These are more helpful if you know exactly what the allergy is, so that when you use them, they're a little bit more specific. They work better that way. Adrenergic agents, they help relieve the severity of the symptoms. They don't necessarily treat the underlying cause. So pseudoephedrine, hydrochloride, Sudafed. Some of your side effects here include things like hypertension, palpitations, irritability, and tremors. So you just want to make sure that you are teaching your patient about that. Your mast cell stabilizers, they are being used primarily prophylactically to prevent the onset of symptoms and to treat symptoms once they occur. So they are helpful for chronic allergic rhinitis. So things like intranasal cromolyn sodium. Uh, so they reduce the release of histamine, and they may take a week or more to manifest. So it may take a week or more to manifest in terms of being helpful for the patient. Steroids, corticosteroids. So for severe cases of allergic rhinitis that cannot be controlled by everything else that we talked about. So either your antihistamines, decongestants, avoidance therapy, none of that is working. Now we're going to try to do steroids, right? Because we already know that steroids are going to suppress your immune system. So this is not going to be our first go-to. So let's see, we have things like beclomethasone, dexamethasone, Flonase, all of these. And so some of their side effects are drying of the nasal mucosa and epistaxis as well. And then the immunotherapy, so this is allergen desensitization. So they're using this one to treat IgE-mediated diseases by injections of allergen extracts. So it's referred to as allergy vaccine therapy. So it involves the administration of gradually increasing quantities of specific allergens to the patient until a dose is reached that is effective in reducing disease severity from natural exposure. So they're kind of giving you little bits of the allergen, and they're hoping that by doing that, your body itself will naturally get stronger and stronger, and then it's going to take care of the allergen, or just not react anymore. So they're banking on natural exposure basically becoming increased. So giving you little quantities at a time. It's kind of like how they let kids grow up. They're saying like when you're born, you're basically allergic to anything, but then they let you get dirty, go play in the grass, whatever. And then slowly over time, the more you do that, the baby basically builds up the immune system in a natural way. Some people would not vaccine their babies actually, because they think that's worse for the baby than just getting natural immunity by just running around in dirt, which is an interesting concept, right? They think natural exposure is the way to go in some cases. Your job as a nurse, you're going to identify the patient's known allergies. You're going to describe the patient's typical allergic reaction, encourage the patient to wear a medical alert band, monitor the patient closely after administration of new medications, and identify early manifestations of allergic reactions. For the contact dermatitis, so remember this is the one that is type 4 delayed hypersensitivity reaction. So this is from direct skin contact with chemicals or allergens, and there are 4 different types which you do not have to worry about. You don't need to know whether it's allergic, irritant, phototoxic, or photoallergic. You just need to know that it's a type 4 hypersensitivity reactions and the types of things that can cause it. So soaps, detergents, and plants even. What are you going to be seeing here? Itching, burning, erythema, skin lesions, vesicles, edema, weeping, crusting, drying, and peeling of the skin. And you are going to be giving topical corticosteroids, including things like hydrocortisone cream if necessary, and antibiotics as well if necessary. So this is a type 4 delayed hypersensitivity reaction. All right. All right, so this is what that may look like. And then your type 1 hypersensitivity reaction. So most any food can cause allergic symptoms. The common offenders are seafood, legumes, seeds, egg white, milk, and chocolate. So pretty sad if chocolate makes you, have an allergy. That sucks. Peanut, tree nut, more severe allergies in about 70% of children. And it's interesting because I really feel like we didn't have a lot of kids being allergic to peanuts, quite honestly. I don't ever remember growing up in my country that kids were allergic to peanuts. Every child I knew was eating some type of peanuts. So it's unfortunate that, I don't know what's happened, maybe it's GMO manufacturing or something. All of a sudden, every child, is allergic to peanuts, and that sucks. So now when you're babysitting, you have to find out, okay, what is a child allergic to? And the list is crazy. And I'm pretty convinced it's because of what's happening to our foods that we're getting these days. It's really messing up our normal natural immune systems and how we are reacting to things. Anyway, so what are you going to see? So this is type 1. So this can get really, really bad. It can be systemic as an end result, right? So look at these funky things you can get. It can be both local and systemic. So urticaria, dermatitis, wheezing, cough, laryngoedema. So those are big ones. Laryngoedema is not a little thing, right? Wheezing also. Your GI symptoms, so things like swelling of the lips, the tongue, and abdominal pain. So anytime you see type 1 hypersensitivity reaction, know that this is the ones that are explosive, they happen right away, and they can literally end up having things like anaphylaxis, and the patient can go into anaphylactic shock. So you are monitoring them very, very closely. So for food allergies, you're doing a detailed allergy assessment, doing a physical examination, and you're basically eliminating the food responsible for hypersensitivity. You're giving medication necessary for those who cannot avoid exposure to offending foods and for those with multiple food sensitivities, right? I mean, though you're giving them meds, anytime they eat that particular food, they're still going to react to it, but you're hoping that the immune response won't be as aggressive, basically. So here's some of the skin testing that they can do for the patch testing. So they have different things, allergens that they've put on the skin, and they're trying to see how your body is responding, right? They're measuring it. So they've put in the suspected allergen, and here there's a positive test. The area is red and swollen. And here they've put a whole bunch of different allergens on the skin, and some of them are reacting, some of them are not. And you may have to do this for patients when you're not sure what's causing the allergic reaction. So you have to keep a food diary, and you have to make sure that you're monitoring everything closely. So focus on preventing exposure to food allergen. You're reading food labels and monitor the preparation of food by others. Which is a good reason why people really shouldn't be going out, because even though they're telling you things are organic or things are prepared without the meat being close by, you can never guarantee that, right? Like if you're allergic to seafood and you're going to a restaurant, half the time they're using the same grill for everything. Like unless they're really, really good and diligent, they're going to have separate grills for things. So then you end up having an anaphylactic reaction because somebody was grilling your, I don't know, your broccoli or something, and somebody else had grilled like seafood on the same thing, right? So you really, really have to be careful when you have allergies, because not everybody is as diligent as to make sure that your food is well cooked and not in the presence of nuts or anything else that can be a problem for you. The patient, they need to know their allergic reactions and signs and symptoms. They need to be carrying an ID and emergency equipment at all times, and they must have a medical alert bracelet on. So if it's EpiPen, they need to have that with them, right? So allergic reaction for latex allergies used to be really common, and this has dropped now because now we're using a lot of non-latex materials, and you can have non-powdered latex gloves as well. So this is still an issue. My mom worked in a hospital for a very long time, and she was allergic to latex, and for a very long time they actually didn't have non-latex gloves in the setting, and she had to buy her own and bring them to work. And what would happen is her hands would just get like swollen, and this would happen over days. I think the powder in there would just irritate her, and yeah, so it got really bad that she had to just bring her gloves from outside because at the time they didn't have the non-latex gloves. So latex allergies are a huge risk for healthcare workers, people who work in factories that manufacture latex. Females apparently respond to this worse too. People with multiple surgeries, obviously, because some of the gloves may be latex. And it used to be a big problem during intraoperative period. Now, like I've said, we have non-latex gloves, so now we're definitely just keeping them away. We don't even have them on the floor, really, because why take the risk? Exposure used to be either cutaneous on your skin or used to inhale the powder, and that's pretty much why people would, be affected. And so if you have contact dermatitis, your skin contact has been basically is that's how you'd have that particular allergic reaction. So some type of skin contact has happened to whatever the allergen is. Then you have other things that are known as allergic dermatitis. So these are things like eczema, because they've had a contact with allergens, and this can happen hours later. They're getting an allergic reaction, and they may call that allergic eczema. So they just have to look at it and assess it and analyze it and see exactly how it's presenting itself. Um, so that's really it with that. I think that's the main thing on this slide. All right, latex allergies. So just a really big history, just like we mentioned earlier as well. Different ways to do the testing. You are avoiding latex, right? Antihistamines, emergency kit, epinephrine as needed. Um, let's see, carry your own latex gloves, and they need to be in a latex-free environment. But like I've said now, that's no longer like the biggest issue. Type 1 hypersensitivity disorders. So some medications can do this to you as well. So some drug reactions appear suddenly, and then the rashes disappear after medication is withdrawn. You may see systemic and generalized symptoms, so bronchospasms, urticaria, and angioedema. Angioedema is definitely not a good thing. Advise the client not to take the medication that they have a hypersensitivity to, and that goes without saying. All right, your nursing diagnosis is going to happen, or it's going to be dependent on what type of hypersensitivity reaction your patient is getting. So, but really, it's about airway. So it's airway, breathing, circulation. Most important, ineffective airway clearance and decreased cardiac output, especially if they end up going into shock, in particular anaphylactic shock, right? Then your mast cells are really, really huge. Histamine reaction, vasodilation is pronounced, so then that becomes a really, really big problem. So anaphylaxis here is the most severe form of allergic reaction. So it's life-threatening, it's unanticipated and severe. You're getting things like vasodilation, increased capillary permeability, smooth muscle contraction, laryngeal stridor, which is the larynx is basically closing, and you're getting a very high-pitched wheezing sound. You're getting things like angioedema, you're getting a blocking that's happening, hypotension, bronchial, GI, or uterine spasms. So anaphylaxis is the most severe form of allergic reaction that can happen. All right, so what are you going to see with the anaphylaxis that's going on? So inflammatory cells are going on, the mediated release of histamine and other mediators, and literally shock, laryngoedema, bronchospasm, urticaria, angioedema, flushing, gastrointestinal symptoms, all of that may be happening. And there are different things that can initiate anaphylaxis, right? So some of it has to do with food, vaccines, blood products, opiates, medications, idiopathic, unknown, so several different things. The main takeaway is if somebody's going into anaphylaxis, shock is the main thing that you're worried about. So things like loss of consciousness, hives, swelling of the tongue, inability to swallow, and rapid swelling of throat tissues, all of that can happen. Okay, this would be considered like a severe anaphylaxis here. Some of your treatment, so assess for severity of symptoms, ensuring a patent airway, administering high flow O2, removing insect stingers if it's present, right? So if somebody got bit by a bee, right, or stung by a bee rather, establishing IV access, giving epinephrine, nebulize albuterol, Benadryl, IM or IV, corticosteroids, all of that. So Benadryl stops the mast cells from releasing the chemical mediators. Obviously, things like epinephrine will open up your airway. All of those different things, right, will be beneficial. Okay. If the patient is hypotensive, you can place the patient in a recumbent position, elevate the legs, you can give things like epinephrine, maintain the blood pressure of fluids, volume expanders, and vasopressors. You are doing an ongoing monitoring, so monitoring vital signs, respiratory effort, oxygen saturation, level of consciousness, cardiac rhythm. You're anticipating for sure intubation for severe respiratory distress. You're anticipating things like cricothyrotomies or tracheostomies for severe laryngeal edema, right? So you need to find an airway for this patient. You do not want them to go into hypovolemic shock, which can lead into things like cardiogenic shock, etc. Right? So all of that is a problem. All right, so you have a patient in a shock position. Keep the person warm and comfortable. Turn the patient's head to one side if the neck is if neck injury is suspected. So this is just one thing that they can do, right? For some of the patients. So it doesn't mean you're going to be seeing this in the hospital for sure. In the hospital, we tend to just give medications as our go-to right away. All right. So you're going to look airway, breathing, circulation, any type of disability, what's the exposure? Is the sting still there from the bee, right? So you're looking for acute onset of illness, any skin changes, you're calling for help, putting the patient flat and putting their legs up, okay? You're giving adrenaline as quickly as possible, so things like epinephrine. They are tightening up the blood vessels to maintain the heart rate, basically to bump up the heart rate, right? Establishing an airway, high flow to IV fluid challenge, different types of medication, chlorpheniramine, that's an antihistamine, hydrocortisone, pulse oximetry, EKG, blood pressure, all of those different things are being given to the patient as quickly as possible. All right, and then these slides are actually talking about autoimmune disorders and all the different types of destruction that they can cause. So I'm not going to spend too much time on these because we've talked about autoimmune disorders under different categories from before. But in general, you can have autoimmune disorders and you're going to end up with things like cell and tissue destruction, let's see, change in tissue or organ function. So for an allergy, the body views as a foreign substance that it would ordinarily ignore as a threat and attacks it. In an autoimmune disorder, the body perceives its own tissue as a foreign substance and basically attacks it. So here you're talking about rheumatoid arthritis versus multiple sclerosis, and we've talked about some of these already and the fact that they're considered autoimmune disorders. Psoriasis as well, type 1 diabetes, all of these are considered autoimmune disorders. So just know that these are out there. Lupus, we've talked about specifically systemic lupus erythematosus. We've talked about the fact that this is considered also as an autoimmune disorder. And we've talked about all the different things that can happen in lupus. All right, so just know that these are some of the ones that are considered autoimmune disorders. Okay. So this is an example of a first question. Somebody shows up in the ED. They've eaten shellfish and they're having things like dyspnea and wheezing. They can't speak and they have a bluish color around their mouth. So what is the first intervention that you're going to do? So first question. So it's always assessment with the first question, right? You're looking at the patient and then you're going to assess them. The client recently diagnosed with SLE, asked the nurse what is SLE and how did I get it? So this is just, it's an autoimmune disorder basically. I think that might be it. The difference between an allergic reaction and an autoimmune reaction. Allergic reaction occurs from exposure to a substance outside the body rather than the body's own tissue. That's the best answer here. Alrighty then. The difference between a typical allergic reaction and an anaphylactic reaction can best be described by which of the following statements. So anaphylactic reaction is an allergic reaction so severe that it is a medical emergency.